Hi, I'm Arman Kamar, a cardiology fellow from the Brigham and Women's Hospital, reporting live from 66th Annual Scientific Session of the American College of Cardiology. I have the prestige here of being with Dr. Khera, a preventive cardiologist from the Mass General Hospital, who is also a researcher at the Broad Institute in Boston. Dr. Khera, thank you for being here with me. So a 4-year trial was presented today. Dr. Sabatine talked about the pertinent findings, and very exciting day at ACC. Also, I think a big day in cardiology. We are seeing in-human translation of findings from human genetics into trial and then seeing that improve outcomes. What's your interpretation of 4 year?
Thanks, Arman, for having me. Yeah, tremendously exciting results. As you know, PCSK9 was discovered as being related to LDL metabolism in 2003 via human genetic studies. And really in only 14 short years, we translated that into a randomized clinical trial, which even on top of statin therapy demonstrated significant benefit for folks in preventing cardiovascular disease. I think the question now becomes, is that risk reduction, 15 to 20%, adequate to justify the cost? I think at scale it actually may not be, but we're at present prices, but we're waiting on the cost-effective analyses. Number one. And number two, I think we're very interested in what subgroups of patients may benefit particularly from these novel biologic agents.
Got it. No, thank you. That's very helpful. Now, in your practice, have you been using PCSK9 inhibitors? And if yes, to what kind of patients are you using them in?
Sure. I'm only now starting to put folks on the PCSK9 inhibitors, and I would say I really look at what do I think the absolute risk reduction is going to be for them, and I think the people who are going to generate the most absolute risk reduction are those with heterozygous familial hypercholesterolemia, those with severe hypercholesterolemia, not otherwise specified, and those with secondary prevention with not adequately controlled LDL cholesterol. And I think that's a logical place to start. And I think moving forward, we're going to find out whether or not PCSK9 inhibition becomes standard of care for all patients who've had a heart attack.
Because the other thing in translating from genetics into human studies, PCSK9 is just one of them. There's a lot of interest in ANGPTL3 and 4 and developing inhibitors to that. Now, the clinicians get confused and they ask, how low is low enough? So in your practice, do you really target for a number, or you follow more of a precision medicine approach in which you say that it's not one size that fits all and decide on a case-by-case basis?
Yeah, I think that it's almost a mathematical possibility that there has to be diminishing marginal returns to LDL cholesterol reduction. I mean, LDL reduction can only reduce the population or individual attributable risk to LDL cholesterol. And so I do think we're going to start to see a drop-off. In my clinical practice, I would say I think 30 to 50 is probably a reasonable sweet spot for now. And as you said, there are a number of totally orthogonal pathways that one might consider to reduce atherosclerotic cardiovascular risk. That could be antiplatelet therapies, that could be future and currently available therapies to reduce triglycerides, that could be some of the new anti-diabetic agents. So when I have a patient in front of me, I'm thinking, do I want to add a new medication? And if so, which one? And which would be the most cost-effective way of getting the benefit to the patient?
Thank you, Dr. Khera. Thank you for spending time with us. We can be followed live on FIT blog on YouTube. Thank you.